everyone. I just want to introduce myself. I am Jordan. I am a nursing student in the MSN program at App, and I am helping with Miss Martin's teaching of the labor and delivery complications. So I'll be doing this lecture today with you, and we will talk about complications that can arise during labor and how we as nurses manage and care for the patients with these situations. So complications can arise from a variety of factors. We are taking care of two patients and we can really only see one. So that in itself is difficult. And the factors that go into labor and the complications are frequently related to what we call the 3 Ps of labor, which are powers, passage, and passenger. And also recently, a 4th and 5th P have been added and referred to as psych and preparation. So those two relate to emotionally supporting the patient and the patients themselves being prepared for birth and labor. A lot of times they take birthing classes, and this helps with the understanding of the process and decreases their anxiety. The powers of labor refer to the strength of contractions and later the expulsive force or pushing efforts by the mother. Sometimes uterine dysfunction can cause these to be ineffective. Passage is related to the birth canal anatomy or the bony pelvis of the woman. Sometimes this can be disproportional in its shape and not allow for an easy passage of baby. Placental obstruction can also affect the passageway. And then the passenger is the fetus, and this passenger, this P, is referring to the lie and position of the fetus in accordance with the pelvis. When the fetus is not in a favorable lie or position, this can lengthen the labor process and necessitate the use of other measures. Multiple babies can also cause positioning to be tricky as there is less space. We will also discuss further these and other medical emergencies that can cause increased risk of intervention during the labor and birth process. So our objectives for this lesson are here. We are going to discuss these dysfunctional labor patterns, talk a little bit about precipitous births and uterine complications, placental variations, and different trials of labor management. We'll talk about some pharmacological uses to induce labor, describe the use of forceps and other tools to help extraction of baby, talk about fetal malpresentation, cord prolapse, and nursing interventions that go along with a lot of these. We'll also talk about maternal and fetal factors associated with cesarean birth. So these slides are just a review of the stages of labor. Complications can arise during any of these stages, and the nurse should be alert and aware of how to intervene during these to provide best outcomes for the mother and the baby. So the nurse really plays an integral part of care for these patients, and they should always be using their critical thinking skills to intervene when necessary. The stages of labor are the first stage, which includes the latent phase, active phase, and the transition phase. The transition phase is often the most difficult in terms of coping and pain for the laboring mother. And then the second stage, which begins when a woman is fully dilated and lasts until expulsion of the fetus. The third stage is delivery of the placenta, and then the fourth stage is from placental delivery to the stabilization of the postpartum patient. So stabilization after delivery often takes up to 1 to 4 hours. So why would we intervene during labor? And what is the nurse's role? So as we have discussed, there are a variety of factors that would require intervention, and the nurse must use the nursing process and critical decision making to determine the appropriate actions. Preterm labor can start before pregnancy has reached full term, and this could cause detrimental effects for the fetus who is not yet ready to sustain life outside of utero. When a mother comes in complaining of things like contractions, bleeding, loss of fluid, etc., it is important to note the gestational age. Preterm labor is defined as labor occurring after week 20 and before week 37. So to stop preterm labor, we often use magnesium sulfate and terbutaline as the pharmacological agents. Magnesium acts as a smooth muscle relaxer and can temporarily cause the uterus to relax, and this hopefully prevents delivery long enough for the patient to be administered terbutaline. So the terbutaline is not necessarily to stop the labor, but it is a steroid that helps with maturation of the fetal lungs. And its goal is to reduce the severity of respiratory complications to a preterm neonate. Magnesium can also offer neuroprotection for the baby. Induction of labor may occur if there are known maternal or fetal conditions that could cause greater harm by waiting longer for the natural labor to kick in or progress, or if the pregnancy has persisted beyond 40 to 41 weeks, so that meaning post-dates has gone on a little longer than normal, which can lead to large babies sometimes and other problems. Augmentation of labor happens when a woman has gone into labor on her own or her body has kicked into labor on its own, but is not progressing for some reason or another medical reason. For another medical reason, we need her to deliver faster. Some of those are like the fetal intolerance, so the baby's not tolerating the uterine contractions or tolerating labor. And if the mother has preeclampsia, high blood pressures, those kinds of things, sometimes we need to speed up the process a little bit. And then the use of instrumentation during delivery to assist in delivery, such as forceps, is sometimes warranted when the mother has trouble with that pushing effort, and this could be due to positioning or fetal hypoxia is occurring during the expulsion efforts, and we need something to help get baby out a little bit quicker. And then finally, a cesarean section is a surgical intervention. It is a last resort, but it is sometimes indicated and necessary. So some basic fetal monitoring for complications. You may have seen this in previous lectures, but is a great mnemonic to remember basic fetal monitoring concepts. These 4 things can tell you a lot about the status of your fetus when caring for pregnant and laboring patients. So you can't see the baby, so you need some way to monitor that patient that is inside, and you will use that fetal monitor a lot for that. So keep these in mind for the next few slides. The acronym VEAL-CHOP, which when aligned side by side, shows you what the changes in baby's heart rate during the monitoring means. So V for variable, which indicates cord compression. E is for early decelerations, which means head compression. A for accels or accelerations, which just tells you that you have a healthy baby usually. And L for late, which means late decelerations, and this means that the placenta and subsequently the baby is not getting enough oxygen, so placental insufficiency. So when would we intervene during labor? Usually when there's evidence that the baby is not stable, or if there are other known factors that could compromise the delivery of a healthy baby or lead to poor outcomes for the mother. So overall, the goal is for everyone to stay well and for us to have a healthy baby at the end of the day. So it is important to remind the patients and the mothers that have to have interventions that some of these are for the health and wellness of her and baby, and that she is doing well, and that these are not anything in her control. And this kind of just helps her to understand that oftentimes we do these things, or these things might need to be done to deliver a healthy baby. So some of the things that we would intervene for would be cord compression, placental insufficiency, or a lack of oxygen for baby, and the other maternal or fetal conditions such as preeclampsia, some heart defects for baby if baby's not getting placental infusion well enough, and there are quite a few others. So when there is evidence of a non-reassuring baby monitor, if it's non-reassuring in the sense of the fetal monitor, then it's usually a cause for intervention. Some initial signs that something is wrong with the baby are meconium-stained fluid, meconium-stained amniotic fluid, and changes in the fetal heart rate. So the meconium-stained fluid basically means that baby has stooled in utero, and this is often a sign from the baby that it is stressed. So there's something going on there. When these things begin to occur, it is important for the nurse to be on high alert and to know when and how to intervene. So here are some quick nursing interventions that can be done before the provider arrives, or if you're just, in the room and you notice that some things are going on and baby's heart rate drops, these are generally the first things that we turn to do. So the nurses must act quickly, as they are generally the primary caregivers until the actual birth of the fetus occurs. In most facilities, the nurse in the labor and delivery unit is guiding the care for the patient, and the OB doctor or nurse midwife is not present until the patient is completely dilated and ready to begin pushing. So they will stop in and check on the patients, but a lot of time the care is being managed by the nurse. So the nurse must use their critical thinking in high-stakes situations to care for these patients. Quick nursing interventions that should occur when the fetal monitor indicates a change in baby or mom are shown here. So positioning on the left side allows for more blood flow to the mother's heart and can increase flow to the baby as well. So it can increase that placental perfusion for baby. Sometimes just changing positions in general can also take pressure off the umbilical cord or get baby into a more favorable position. An IV fluid bolus can increase the volume to relieve compression, and then turning off medications such as Pitocin can help reduce the activity of the uterus, allowing baby to get better oxygenation. Another somewhat currently controversial intervention is placing oxygen on the mother. So this has been done for a long time, and it was believed to have helped increase oxygen for the baby. However, there are currently no sound studies to uphold this. So more recently, this is not practiced regularly. And even more so with COVID today, this is not recommended in a lot of hospitals, and they are wanting us to not do this, as this is an aerosolizing procedure and it can put the staff at risk for exposure. It is recommended if the mother's oxygen is actually low. So if you're monitoring mom, usually the mother is also having her blood pressures taken regularly and is on a continuous pulse ox to monitor her oxygen level. So if that is low for mom, then yes, we should put oxygen on the mother. But if baby's heart rate is low, this is not indicated particularly to help the baby, if that makes sense. And we can talk about that a little bit more after the lecture. So dysfunctional labor patterns, there are two, hypertonic and hypotonic. Hypertonic is generally when labor contractions are strong and often painful, but are ineffective in producing cervical effacement and dilation. So even though the woman is having these strong contractions, she's not progressing in labor to be able to deliver the fetus. A lot of times this is caused by maternal anxiety. So the body is just not allowing that relaxation between contractions. And instead, irregular spasmodic episodes are occurring that do not result in effective contractions or assist in bringing the fetus into a more favorable downward position. Maternal anxiety, again, is known to produce high levels of catecholamines, which increase the muscle contraction, and many factors can contribute to this anxiety. So birth is scary. The woman has fear related to the pain. This might be her first baby. She has a fear of that loss of control feeling. She may have a history of sexual abuse or lack of support, and then cultural differences as well. So all of these things are things that we need to think about when we are caring for our patients and intervening. Another reason is occiput posterior malposition, so OP position of the fetus. This occurs in approximately 15% of labors, and it does lead to hypertonic labor contractions in general. So the major goal of care here is to facilitate rotation of the fetal head into a more favorable position. So we ask the patient to walk around, help her change positions frequently if she has an epidural. And then there are a few other things you can do to kind of help reduce this hypertonic state. Rest, hydration, and sedation are generally what we turn to. So the sedation can help reduce the irritability of the uterus and help to diminish the ineffective contractions. Medications that we use frequently for that are Demerol, Dilaudid, and sometimes morphine. Generally, after you give the mother and the uterus a rest, natural labor with effective contractions often resumes. And there are other non-pharmacological techniques that can be used to reduce anxiety, such as relaxation, massage, a warm shower, or using a tub for some tub bath. Increased emotional support. Some people do not have a support person there during the labor, so the nurse is going to have to jump in and play that role just to help her understand the process and to feel more comfortable with what's going on. The second dysfunctional labor pattern is hypotonic, and with these, the contractions decrease in frequency and intensity. It basically is a state of, it is a more common type of uterine dysfunctional pattern, and it is a state of decreased intensity for the contractions. So the pattern usually occurs after the active phase of labor. It is defined technically as fewer than 2 to 3 contractions during a 10-minute period. It may be associated with a number of maternal or fetal factors that produce excessive uterine stretching and overdistension. For example, large babies, fetal macrosomia, anomalies, malpresentation, multiple gestation, so if there are more than one baby, hydramnios as well, are all factors for hypotonic labor. In addition, grand multiparity, so mothers who have given birth more than like 3 or 4 times if they have had several births, and maternal obesity are also contributing causes. Pharmacological agents that we use to alleviate pain during labor may also contribute to the risk of uterine hypotonia. So with these, if the mother has a very dense epidural, or if we've given her a lot of other IV medications, the labor pattern is not well established, and these medications can often halt or significantly slow down the progress of labor. Walking and position changes again will help the fetal descent through the maternal pelvis, and therefore the use of relaxation techniques, massage, the water treatments can decrease the need for these pharmacological agents for pain. Augmentation of labor contractions is considered when either the natural measures are unsuccessful or when it is deemed the best approach. So at certain points in the labor, we may have to artificially rupture her membranes to increase uterine contractility. Other measures to enhance the progress of labor, including membrane stripping, nipple stimulation, and Pitocin or oxytocin infusion. So those are all kind of things that we can do to augment a person's labor. Precipitous labor and birth is contrary to both hypertonic and hypotonic labor. So precipitous labor contractions produce very rapid, intense contractions. And by definition, a precipitous labor lasts less than 3 hours from the beginning of contractions to birth. Patients often progress through the first stage of labor with little or no pain and then may present to the hospital or the birth setting already advanced into the second stage. In a nulliparous patient, cervical dilation that occurs faster than 5 centimeters per hour is defined as precipitous labor. In a multiparous woman, cervical dilation may occur as rapidly as 10 centimeters in 1 hour. Precipitous labor may result from hypertonic uterine contractions, and this can be very intense for the patient. So they may come in being very verbal about their pain and about what is going on. They are usually very fearful and have a lot of anxiety. So it is the nurse's responsibility and to help them cope with that and to instruct them and teach them on ways to manage that this process at this point. So there are complications also that can arrive from precipitous labor. So it sounds like, labor that's going really fast and it's all natural. That sounds great. But again, it is very scary because everything's happening very rapidly. If a patient was hoping to get some kind of, pharmacological pain intervention, they often are too far along and cannot get this. So this precipitous labor pattern can result from trauma to the maternal tissue and to the fetus because of rapid descent. So the complications can result from that. So basically, if baby comes down really fast and is born really quickly, hemorrhage may occur from a uterine rupture or vaginal lacerations. Most women are not prepared for this, so they, again, are very highly anxious and fearful. So it's important to continue to tell them what is happening, what is going on with their baby, and to just encourage them to get through this period of this birth. So the fetus may also suffer from hypoxia related to the decreased periods of uterine relaxation between those contractions. And they can also have sometimes intracranial hemorrhage related to the rapid birth. A lot of bruising can be seen on the face sometimes. So there just are various things that can happen when this labor progresses very quickly. Amniotic fluid complications. There are several. Oligohydramnios is a small amount of fluid, so it's less than 300 milliliters of amniotic fluid. Hydramnios or polyhydramnios is a lot of fluid, which is greater than 2 liters of amniotic fluid. And then the presence of meconium, which is the first stool of the infant, in the amniotic fluid can complicate the labor and birth process. And with all of these, the nuchal cord sometimes is involved in this. So with the oligohydramnios, you can have cord compression during contractions, and with the hydramnios, with a lot of fluid, the baby can move around a lot and the cord can get wrapped around various things when it has more room to float around. So there are definitely complications that can occur with both of these. So oligo, again, may result from renal abnormalities, so the baby may not be able to swallow the amniotic fluid properly and excrete that. Poor placental perfusion or premature rupture of membranes, the patient is constantly leaking amniotic fluid and decreasing that volume. So during labor, the absence of the amniotic fluid buffer can lead to that cord compression during the contractions and decreased fetal blood flow. You will see this come up as the variable heart rate decelerations on the monitor. So the variable heart rates are when that heart rate drops really quickly and then kind of comes back. So it looks like a V, so V for variable. They are generally not emergent if they are not excessive. So it is important to try to intervene, move positions, get the baby off the cord. Trying different things like that can help with that cord compression. But unless they are very, very frequent, then we generally do not worry too much about these. Hydramnios occurs when there are multiple gestations, so those babies need more fluid. Fetal anomalies, and as a complication of maternal disease such as diabetes. During labor, the nurse needs to be aware that the excess volume of fluid may obscure the fetal heart rate tracings. Hydramnios can cause fetal malpresentation because of the extra uterine space that it provides for the fetus to turn. So being aware of this and knowing that even though baby was head down, once labor starts progressing, that baby may still be able to move around and you may end up with a different presenting part. And then, of course, the cord may be wrapped around different things where baby has gotten entangled in that, floating around. The meconium staining, which occurs in approximately 20% of births, is observed more frequently in prolonged pregnancy, so when the patient has gone past 40 weeks. Obstetric interventions that we can do for some of these, an amnio infusion. So pregnancy outcomes in patients experiencing variable fetal heart rate decelerations caused by cord compression is improved through the use of this amnio infusion. So what this means is that we instill some kind of fluid into the uterus. So normal saline or lactated Ringer solution is usually what is used. And it can be used to supplement the amniotic fluid volume with oligohydramnios. It can be kind of put in. We usually want to warm it before we put that in because it can kind of lead to sort of a shock factor for a baby if you're instilling really cold fluid into the uterus. And there are risk with this procedure as well. So those include infection because you're entering the uterus with some kind of tools and you're kind of doing this invasive procedure. So there's always that risk for infection, overdistension of the uterus, and increased uterine tone. So in most circumstances, the fluid is instilled through a intrauterine pressure catheter, which we call an IUPC. The amniotic membranes must be ruptured for the catheter to be placed. And this is so that they can get in and kind of place this catheter and put this fluid in there to help with that low fluid levels. Obstetric interventions, another one is amniotomy, so artificial rupture of membranes. We call this AROM, A-R-O-M. This is a non-pharmacological intervention that may be done to augment or induce labor or to facilitate the placement of the internal monitors, so the IUPC, during labor. AROM is a procedure that involves the insertion of an amni hook into the lower segment of the fetal membranes. Following rupture, the fluid is allowed to drain slowly. You will sometimes get a little bit of a gush, but then there is generally a lot of slow drain after that. The rupture of the membranes does cause a release of a certain enzyme which converts to a prostaglandins, and these are known to induce labor through stimulation of oxytocin in the uterus. It's important from the nursing standpoint after this and during this procedure to monitor vital signs, cervical effacement and dilation, station of the presenting part, fetal heart rate, and the contraction. So kind of knowing what's going on with your patient. This is kind of a big deal. You're releasing all that fluid that's been protecting the baby, so you really need to be on high alert to watch out for these changes that may occur during this process. When this is done, when we rupture fluids, labor usually commences within 12 hours of artificial rupture. However, if labor does not ensue, there is an increased risk of infection. Other risks include fetal injury and umbilical cord prolapse. And because of the risk for infection, amniotomy is frequently used in combination with oxytocin induction to facilitate delivery faster. So we don't want the mother sitting there with ruptured membranes, no protection for baby for very long. In general, most providers and hospitals do not want them to go longer past 18 hours with ruptured membranes. That varies per provider and facility, but just be kind of aware that 18 hours is sort of that magic number as far as how long that they should be ruptured. The presenting part must be engaged and well applied to the cervix to prevent umbilical cord prolapse, which is protrusion of the umbilical cord in advance of a presenting part. So basically the umbilical cord has moved past the baby's head and it might be coming out first instead of the baby. There should be no evidence of active infection in the genital tract, so herpes or HIV infection. You don't want to rupture those patients because baby really should not be passing through the birth canal at that point, so they would be more candidates for a C-section. Okay, so we're going to talk about induction of labor. Some indications for induction of labor would be if the health of the mom or baby is at risk for some medical reason, so preeclampsia, infection, those kind of things, or if the pregnancy has progressed beyond 40 to 41 weeks. Generally 41 weeks is the goal, but if it goes past that, there are problems that can occur with the baby. The baby can be larger, require more insulin, just different kind of things that there could be more high risk for shoulder dystocia. So once baby gets bigger and they start running out of fluid and the placenta starts to deteriorate and sort of get these calcifications, they're not getting enough placental perfusion, those can be reasons for induction of labor. Induction describes the use of chemical or mechanical modalities to initiate uterine contractions. So this is before the mother goes into labor on her own. And it is considered to be one of the most common obstetric interventions in the United States. The rate of labor induction rose from 9.5% to 23.2% of all deliveries between 1990 and 2010. So that could be related to just changes in the medical world with advancements, things like that. We are creating more medications, more tools that are allowing us to intervene more frequently and with different patients and things like that, whereas we didn't have those before. Is usually considered when either a maternal or fetal condition exists that dictates the need for medical intervention. Labor induction often leads to increased interventional care, so the nurses need to be there to support them more. They will need IV therapy. They will need internal monitoring sometimes. They typically will need an epidural, or they want the epidural because of the medications we're giving them is causing stronger contractions. The things that we're doing are painful a little bit for them. So a lot of times they need those extra pain measurements to help them out. And in general, they tend to stay longer in the labor unit. So there is that factor of letting the patients know that this is not a process that can happen, that usually happens very rapidly if their body is not ready for labor, but it may be necessary for the health of mom and baby. So the Bishop score is a tool that we use to basically tell us if the cervix is favorable or inducible. So sometimes the provider, in deciding if they should induce someone, they go to this tool and they kind of look at where the patient is on this and they score them, and that tells them whether or not the induction is more likely to be successful. The Bishop score is a rating system. It is a series of points that are awarded for cervical dilation, effacement, station, consistency, and position. In general, labor induction is more likely to be successful with a higher score, so 9 or more for a nulliparous woman or 5 or more for a multiparous woman. So if it is determined that the cervix is not favorable for induction or for oxytocin induction, then sometimes a chemical ripening agent must be used to soften the cervix. So we usually use Cytotec or Cervidil, or a catheter with a balloon on the end. So these things can kind of help that cervix to efface faster and dilate. They are most beneficial when the Bishop score is greater than 6. However, they are commonly used when it is less than 4. So those patients, you may need to follow a little more closely for complications from a nursing perspective. Just kind of making sure that baby is still healthy and that mom is tolerating the process. A lot of these medications can be administered different ways. So Cytotec can be administered intravaginally, orally, or sublingually, and is used for both the cervical ripening and for induction of labor. So with augmentation of labor, basically augmentation is used when the mother has already gone into labor on her own, and we are just kind of helping her along. So oxytocin is that hormone that's produced by the pituitary gland, which stimulates uterine contractions. It can be either used to induce from the beginning or to augment the labor that is progressing more slowly. It is administered in an IV infusion device. It is closely monitored according to institutional protocols, and generally the nurse is the one monitoring this whole process. So this is a big nursing intervention for laboring patients. A lot of hospitals have adopted a low dose and high dose oxytocin regimen. The low dose generally begins at 2 milliunits per minute, and then you increase that by 2 per minute every 30 minutes until less than or equal to 5 contractions lasting 45 to 90 seconds in 10 minutes averaged over 30 minutes. So you want to just make sure that you are getting adequate contraction pattern to know that this is effective. The maximum dose for oxytocin is 20 milliunits per minute. On the high dose regimen, they usually begin at 4 and they go up by 4 every 30 minutes till the same thing happens. So that progression of contractions is showing that the body is doing something, is kicking into labor on its own. So this oxytocin acts on the receptors in the myometrium to create an increase in strength, duration, and frequency of the contractions. Sometimes with this, you will get uterine tachysystole or hyperstimulation. So this is a major risk associated with this medication. You have to be aware of your contractions, what's going on with your mom. If you start to see that hyperstimulation, you need to turn the Pitocin down or off. Because if the uterus is contracting so frequently and there's no rest period in between, then the baby is not getting enough oxygen. So you will often see a non-reassuring fetal heart rate and pattern. Sometimes you will see absent variability, and you will see repeat late or prolonged decelerations. So in that case, you need to call the provider, you need to turn the oxytocin off. Sometimes you need to reposition the mother. So doing all those things to kind of get baby into a better position, allow more oxygenation for baby. Instrumentation and the use of these for assistance of birth is not that frequent anymore. However, it is needed and indicated when the baby is not in a position that it can pass through the pelvis. And sometimes if the baby is showing signs of distress and we just need to help the mom with her pushing efforts, so those powers of labor, if she's so tired and she can't push effectively and baby's just kind of stuck there, they start to have distress, they can't breathe well, or they're not getting oxygenated, then we need to try to help the baby out. So in that case, if baby's turned the wrong way, sometimes the providers will use these forceps to turn the head. You can kind of see from the pictures here, these forceps are being used to turn this baby in a different position. Or we also sometimes will use a vacuum extractor, and this is basically just a suction cup that is attached to the baby's head, and the provider is in control of how much suction pressure they are putting on. But there are a lot of risks associated with this as well. So the provider needs to be well trained to use this. It can cause hematomas on the baby's head and other birth problems. It can, if they attach it in the wrong place, I've actually seen them attach it near the eye, which is terrifying. So just think about that really strong pressure pulling on that baby's eye. Or with the forceps, if they do not apply those in the correct place, it can cause a lot of damage to the baby's face. It can break bones, those kind of things, cause skull fractures. So just really high risk. You have to really be alert and aware of what is going on with the use of these to know what baby might need after delivery. So you may want to call in your NICU team, your specialized teams to help care for babies when they have to use these instruments during birth. And last but not least, cesarean birth. So this is usually the last resort. We don't love to go into the OR, but sometimes it is a necessity. It is basically the birth of the fetus through the abdominal incision into the uterus. It is performed to preserve the life of the mother and her fetus, usually. However, today, cesarean sections are the most common operation in the United States. So we have to be cognizant of patients who want to do this just because they do not want to go through the labor process. Generally, that is not a medically indicated reason for that. And the providers will be the ones kind of discussing the plan with them and telling them about, the indications for this or for not to use this. It is performed really when there are medical risk factors that necessitate this. So hypertensive disorders for mom, active infections, genital herpes, and positive HIV status. And diabetic mothers sometimes need this because the babies end up being really large and they do not think that the baby will pass through the pelvic cavity. And then fetal complications most closely associated with cesarean birth are malpresentations, breech babies if they are upside down, or shoulder dystocia, placental abnormalities, dysfunctional labor patterns, fetal distress, multiple gestation, and if you experience an umbilical cord prolapse. So we'll talk a little bit more about that and some of the others in more detail as we go. But among all women, there are 4 medical risk factors that really increase the likelihood of her chance of having a cesarean birth. And those generally are pregnancy weight gain greater than 40 pounds, the diabetes again, the hypertension, and then chronic hypertension. So not necessarily just hypertensive during labor, but if they were chronic hypertension, they're going to be more likely to have problems with that during the labor process. It is a major surgical procedure that carries risk and complications. It is associated with a host of potential post-op problems such as hemorrhage, DVTs, thromboembolus, and infection during the postpartum period. The surgery can result in chronic pain from scar tissue, urinary tract injury, adhesions. You can have wound problems with infections, and there can also be placental problems for subsequent pregnancies. There is a greater likelihood that that the mother with a cesarean birth will have another cesarean birth after that. So we do sometimes give them a chance to try to have a vaginal birth, which we talk about a little bit as a TOLAC, or a trial of labor after cesarean section. But there are risks associated with that are uterine rupture. So she has this previous scar, there is weakening of that uterus in that area, and she could be more prone to have a rupture of that. neonates sometimes born via cesarean section are at increased risk for respiratory problems. They sometimes can swallow more amniotic fluid. They're not getting that squeeze they are when they come out vaginally. Swallowing that and aspirating fluid can cause pneumonia, which can lead to NICU stays for baby, and it can also lead to asthma in childhood and other problems as they grow. So generally there are two main types of cesarean operations, the classic or vertical incision and the lower segment transverse incision. The surgeon chooses which incision type based on the patient's condition and the fetal status. Rarely used today is the classical cesarean incision, and it is reserved for shoulder dystocia, placenta previa, or when the birth must take place immediately. So if they need to go in really fast to save baby or mom, then they will usually or sometimes do that vertical incision. So that's this one here. Also in births in other countries. So if you encounter patients who do not have prenatal records with them, if they can't really tell you a lot about their birth in the country that they had that in, just be aware that there are a lot of third world countries that because of their resources or lack of resources and things like that, sometimes these patients are at more high risk and they have these vertical incisions. So you really need to be aware of that. Those patients cannot deliver vaginally. There's a very high risk of abruption and hemorrhage with that. So it's really important to kind of figure out what she had before. If she does not know, sometimes the providers will go ahead and recommend the C-section for them just as a precautionary measure. The lower segment cesarean section is usually what we use today. So this low transverse incision, it's a lot of times preferred by women for cosmetic reasons. You can't see it when you're wearing a bathing suit. It's just cosmetically looks a lot better. And it may involve either a vertical or transverse uterine incision. So just because the incision on the outside is one thing, the one on the inside can be the other. The transverse incision is more commonly performed, is associated with less blood loss, fewer postoperative infections, and less complications later down the line. So these patients, if they have subsequent births or subsequent pregnancies and they want to do a trial of labor after cesarean section to ultimately get that VBAC, the vaginal birth after cesarean section, some of them are candidates for that. So we just need to kind of be aware of who are or who are not candidates for that trial of labor. So the process of the C-section, basically the skin incision occurs, and then after the skin incision, there is a uterus incision, and they remove the layers and they get down to where the baby is in the uterus. The fetal head is gently brought through that opening, and at that point, the provider usually kind of leaves baby where it is enough to clear the airway. Then we make sure baby's airway is patent, and then we deliver the baby. So the cord is clamped and the newborn is placed sometimes in the arms of the mother or the father. And then sometimes it is placed with the nurse to go under the warmer. A lot of times babies after C-sections have that little bit of a stunned coming out period where they come out sort of flaccid. They are not breathing on their own yet. So a lot of times we need to do a little bit of interventions for this baby, and then baby can be taken back to mother and father. And so we just kind of have to monitor that and see what's happening in order to determine where baby should go. After the placenta is removed, then each layer is again sutured. So there is a suture for the internal uterine incision and then also for the skin incision. And then usually it is covered with a bandage of some sort. So I talked a little bit about VBACs earlier. So VBACs are vaginal birth after cesarean. We talked about how there is a higher risk for certain incisions to have a greater risk for hemorrhage or rupture if they have certain ones. Rupture of the uterus is fairly uncommon, but it can happen. So being aware of that before we give these patients the options for this VBAC is important. other complications that can occur prior to labor, and even without that previous C-section, moms can still have uterine rupture. And so this is an obstetric emergency. They are rare but life-threatening. It usually occurs 1 in 1,500 to 2,000 births. It is most often associated with the tearing of a uterine scar, like I said, from the previous C-section, or it can happen because of trauma, so like car accidents, violence. Sometimes if the patient was involved in any kind of violent encounter, those kind of things can cause ruptures as well. Rupture of the uterus occurs more often with multigravidas because of the distension, the stretching out of the uterus that has occurred previously. And then also if they are having a difficult birth and they use those forceps or assisted things, that can also cause uterine rupture. Uterine inversion is just basically the uterus is turned inside out. It is very, very rare, but it is very important and life-threatening when it happens. So it's very important to act quickly. A lot of times that inversion is caused by pulling on the cord. So when the baby is born, the provider will usually provide some downward, very minimal traction on the cord to help with the separation and delivery of the placenta. But there are times that excessive pressure and pulling does happen, and that can cause that uterus to break and rupture. In that case, that is very urgent, and we do need to start preparing for a dilation and curettage of the uterus. So the provider will usually go in and remove the remaining fragments of the placenta, and also you need to prepare as a nurse for blood transfusion, making sure she has adequate IV access, getting all of your necessary resuscitation equipment together. So it can be very, very detrimental and important for mom for us to do these things. So an umbilical cord prolapse. It occurs when the loop of an umbilical cord slips down below the presenting part of the fetus. There are varying degrees of this. So an occult cord is basically when the cord cannot be seen during the vaginal exam, but it is being pressed on by the baby's head. So you may not feel it, as you can see in figure A here. You may not be able to feel it because you're feeling the top of the head, but then somewhere along beside the head is the cord and is getting squished against the pelvis with the baby's head. So those usually will show up on the fetal heart rate monitor. And it may show up as variables or late decelerations, but basically baby is not getting perfusion at that point, and we would need to do interventions to help that. Complete is when the cord is felt and pulsate is it's kind of a mass and it's pulsating as you do the vaginal exam. You may not see it, but you may feel that ripple of the cord on your hand and you can kind of feel that pulsing. So that is when it's complete, but you cannot see it actually protruding through the vagina. A frank cord prolapse is when you go to check the mom and you can actually see the cord hanging out. All of these are typically emergency situations that need to be remedied very quickly. What we can do for those is to change positions and to get the pressure off the cord. So if the nurse recognizes that this is happening, fetal bradycardia and variable decelerations during contractions are usually observed, and prolonged cord compression causes fetal hypoxia, so we need to fix that. It can cause 5 minutes of that, can cause very detrimental central nervous system damage and even fetal death. So to relieve that pressure, the nurse basically places a sterile glove on her hand and goes into the vagina and manually lifts the presenting part off the umbilical cord. The patient is sometimes changed into different positions. You can use a Trendelenburg position. You can turn the bed with you can use the bed like controls to tip the bed back the other way. So basically her head is lower than her feet, and that kind of makes the baby slide backwards back into the canal and relieve some of that pressure. Knee chest position is one that is used very frequently. We kind of turn the mom over and get her on her hands and knees, This allows baby to drop down and relieves pressure as well. And then also just pushing the baby back up. So sometimes we call this riding the bed to the OR, and you actually will ride the stretcher or the bed with your hand in the vagina to keep the baby pushed up and off of the cord. So at that point, that is your duty, and you ride back while they are prepping the OR, and when you get back there, you don't move until they are able to get mom prepped to make that incision to get the baby out as quickly as possible. So these are very true emergent situations in the L&D world. Fetal malpresentation is when the baby is not in the correct position within the birth canal. This can lead again to problems with getting baby out. Prior to going into labor, the mother and provider may choose to attempt what we call as an external cephalic version. This is only done by the provider. The nurse would never do this, but it is an attempt to turn the baby into a different position that will work better for birth. These positions that do not allow baby to pass through can also lead to shoulder dystocia. Baby's head is out, but the shoulders are stuck within the bony pelvis. This is also a medical emergency. Baby is being compressed, and we have to get the baby out. So complications for mom can also arise. Generally, they will have larger lacerations, and because of the baby being kind of stuck there, she's bleeding during this time, so it can cause excessive bleeding as well. Baby injuries, brachial plexus injury, and clavicle fractures can occur. So the treatment is really geared towards shifting the baby so that the anterior shoulder can pass under the pubic bone. The picture here demonstrates the use of McRoberts maneuver. So you have the mom lay flat on her back, you flatten the bed, and you push her legs towards her chest. And then another nurse puts pressure right above the pubic area, which is called suprapubic pressure. And the goal is to push that anterior shoulder down so that it can pass underneath the pelvis. And the provider at that point is directing the head and turning baby to allow for that rotation for baby to be delivered. Placental variations that can occur that can affect the labor process are usually related to abnormal adherence of the placenta. There can be placental accreta or increta or precreta. The cause is unknown, and these can lead to major problems for mother and baby. This placenta can kind of be adhered to the wall of the uterus and can fail to deliver, causing excessive bleeding for mother. So nurses, again, in this situation need to be prepared for emergency transfusion. They need to call in the resuscitation teams to be able to assist with these kind of things. This requires more than just the doctor and one nurse. You need several people of your interdisciplinary teams to be collaborating to kind of make all of this work and happen as quickly as possible to save the mom. Another really rare but really terrible and really deadly complication is amniotic fluid embolism, or AFE. With this, you have to watch really closely. It happens right after birth, and it is very, very fast. It generally leads to mortality or severe defects for mom. It kind of presents with acute dyspnea and severe hypotension. Sometimes you will notice basically mom just all of a sudden feels this severe anxiety, and she starts to express that to you, and then all of a sudden she is coding, and you're kind of there wondering, oh my gosh, what's going on? You don't really have time to think about it, but the first thing you should think of is if the mom has shortness of breath, severe hypotension, and that anxiety is AFE. Rapid delivery must happen if the fetus is still in the mom, and it becomes an ethical conflict basically at times, which is really terrible. But you have to kind of decide whether or not to save the mom or the fetus. Thankfully, I have not experienced this as a labor and delivery nurse myself. I've heard lots of stories about it, and so I am on high alert watching for that whenever I have a patient, but I have not experienced it myself. I think Ms. Martin has, and she may opt to discuss that with you in our in-person meeting, but basically the nurse's role is to support the family using therapeutic communications and to assist with any emergent resuscitative efforts for the providers and other team members. So if you have any questions, we will address those during the in-person class on Thursday. And thank you guys so much for listening and allowing me to practice my teaching skills on you. Thank you guys.